منا شقية ولا محرومة. إن شاء الله you can start.
Shukran, brother Al-Kifli. Aisha, are you here? Just to confirm.
Yes, I'm here. Assalamu alaikum, everyone.
Wa alaikum salam wa rahmatullahi wa barakatuh. That's our presenter. Dr. Bajaber, are you in? Is Dr. in yet before we start? Okay. So we give him a minute and then inshallah we start. Sorry, Aisha, meanwhile you can just be presenting your screen, yeah?
Okay. Is it visible?
Yes. You can start.
Okay. So I'm presenting a case of severe malaria.
Please just zoom in kidogo. Sorry.
Okay. I don't know. Let me try.
Okay, just continue. It's okay. Achatu, continue. Sorry.
So this is a female patient, 12 years old, from Kangundo, Nairobi. She was admitted on 11th April 2022. She is a referral from Malaria Hospital. Her chief complaint was headache for 5 days, abdominal pain for 3 days, yellowness of eyes, fever, and vomiting for 2 days. Her history of presenting illness: she was well until two weeks prior to admission in KNH, where she developed headache, which was sudden in onset, present in nature, and radiating with no diurnal variation, moderate, which was relieved by paracetamol. Is the handwriting very small? Can just take it.
I think that's better.
Okay. 1 day later, she developed general abdominal pains, sudden in onset, food dull in nature, associated with diarrhea 8 times in 2 days. Mother could not describe the nature of the stool, but she said that it was normal in color. The diarrhea was aggravated by eating and relieved by taking flagyl tablets. She developed yellowness of eyes 2 days later, which was gradually moved to the whole body. It was associated with gradual intermittent fever, which was high in nature, associated with general malaise, joint pains, and tachypnea. The fever had no diurnal variation, and it was also relieved by paracetamol. On the same day, she also developed vomiting. At first, it was non-projectile, non-villous, non-bloody, foul-smelling, and large in quantity. It was postprandial and consisted of the food that she ate. Later, she vomited coffee ground vomiters 4 times after being put on IV fluids. She had episodes of altered consciousness, lost appetite, difficulty breathing, palpitations, and easy fatigability. However, she did not have any episodes of seizures. Mother also reports reduced urine output. She would pass urine only once a day, which was very concentrated in nature. However, she had no urinary urgency, frequency, nocturia, painful voiding, or bladder discomfort. She did not report pale stools or body excoriations. They had traveled to Kisumu 2 weeks prior to the illness. She was taken to Kayole Hospital 2 days after the onset of her symptoms, whereby she was diagnosed with malaria. She was given tablets, which the mother does not remember the name, but the symptoms worsened according to her. She was taken back to Kayole Hospital after 5 days. They put her on IV fluids, after which they started vomiting. After which she started vomiting dark coffee ground vomiters. She was immediately taken to Mama Lucy Hospital, whereby she was transfused 1 pint of blood as blood samples were taken for testing. Blood slide was done and she was positive for malaria parasite and started on artesunate. They said she had kidney failure and was referred to KNH for further management. So her past medical history, this is the second admission after Mama Lucy Hospital. She had no non-chronic illness, no previous blood transfusions. For family history, she is the only child of a single mother, no history of chronic illness in the family, and no history of sudden death in the family. For social history, they live in Kangundo in 1-bedroom apartment. The mother is a businesswoman. They are NHIF beneficiaries. They drink boiled water and they using gas cooker. Her review of system was non-significant. On general examination, she was sick looking, lying in bed in respiratory distress. Her GCS scale was 13. She was on oxygen therapy, non-rebreather mask at 15 liters per minute. She was in good nutritional status with normal hair color and distribution. She had no bony prominences or muscle wasting. She had normal height for weight. She had scleral jaundice, palmar pallor, but no cyanosis, no clubbing, no edema, no wasting, no lymphadenopathy, and no dehydration. Her rest rate was 60 breaths per minute. Pulse rate was 123, and the blood pressure was 115/67. Temperature was 37 degrees, and the oxygen saturation on mask was 88, without mask was 79. Her systemic examination, the abdomen was flat, no scarring or surgical marks, no distended veins, no discoloration. It was moving with respiration. On superficial palpation, there was rigidity but no tenderness of palpable masses. On deep palpation, there was non-tender hepatomegaly and splenomegaly of 8 centimeters below the costal margin. On auscultation, there were normal bowel sounds, but no bruits were heard. On respiratory examination, the chest was symmetrical in shape with no visible scars. There was mild lower chest wall indrawing. On palpation, the chest was not moving adequately. On percussion, the chest was resonant. On auscultation, there was inspiratory crepitations on the left lower side of the chest. CVS examination, she had delayed capillary refill of 3 seconds. She had rapid pulse that was regular with normal volume. There was no radial delay, no Janeway lesions or osseous nodes, no visible JVP. She had normal precordium with no hip or frills. Her apex beat was at the 5th intercostal space mid-clavicular line. On auscultation, there was loud S1, S2, but no murmurs were heard. On CNS examination, her GCS scale was 13. Pupils were sluggishly reacting to light. She had normal muscle bulk and tone, however, her muscle power was at 3. In summary, this is H8. Sorry.
Sorry. Assalamu alaikum.
Salam.
Sorry for joining in late. I would want you to just go up a little bit. Yeah, just that's it. So before you proceed, I think the whole purpose of these ground rounds is to learn. And so maybe we could just brainstorm a little bit and we open this to the other students. What do you think the differentials would be at this point? I think you've mentioned I would have suggested if the main presenting complaints we had highlighted or bolded them, but I think we all captured some of the main presenting complaint together with the examination findings. So you could put it in the chat and on what you think the differentials would be.
F. Gulav is here. Hello.
Yes.
Yes. My name is F. Gulavis. I think one of the differentials would be acute. It would be viral hepatitis.
Viral hepatitis. Okay, good. Based on what?
Based on the jaundice, abdominal pain, and the palpable non-tender hepatomegaly, but also with the history of with the history of fever, jaundice, and hepatomegaly.
Okay, that's one differential. Another one. Someone has said, let me read the chats. Cerebral malaria due to CNS involvement. Okay, there was CNS involvement, Aisha, right?
Yes, her GCS scale was less than 15.
Okay, great. What else? There's something that would not be top of the list, but it could be. We had fever. We had there was a respiratory finding there. There was some crepes.
She had crepitations on the left lower chest.
Yes.
A contribution here.
Yes.
This is F again. I think one of the other differentials would be organophosphate poisoning.
OPP, yes, but
Yes.
also the
Yes.
what more common things happen more commonly, yeah.
Yes.
Even pneumonia, you wouldn't go wrong with a pneumonia differential, yeah, in a setting of malaria. We can proceed. I think I wanted you to block. I didn't want you to proceed because I didn't want you to give away your differentials. But
So
you can summarize and
summary, this is a 12-year-old female patient who presented with headache, abdominal pain, yellowness of eyes, fever, and vomiting, coughing ground. She was in respiratory distress, had palmopala and scleral jaundice. She also had inspiratory crepitations on the left lower chest and non-tender hepatosplenomegaly. So my differentials were severe malaria with acute kidney injury. That was my number one differential. And then I was thinking also septicemia, severe pneumonia. So my impression was acute kidney injury secondary to severe malaria. Investigations, they did peripheral blood slides, they did full blood count, ECs, liver function tests. So peripheral blood slide was negative in KNH. Full blood count was done, and it started high. The leukocytosis, it was at 6.5. As the treatment progressed, it was lowering. And then she also had neutrophilia, lymphocytosis. She had severe anemia with hemoglobin of 5.8, and her platelet was very low. She had thrombocytopenia. And her UECs were also high. For urea, it was 40. Creatinine was 540, which indicated acute kidney injury. And then for her liver function tests, it was also high. The total bilirubin was 319, direct bilirubin was 248, AST, ALT, all of them were high. Her albumin levels were very low. They were moderately low. So for blood gas analysis, she had acidosis. And then CRP was done on 14th April. It was 106, which was very high. And as it progressed, as the treatment progressed, it was lowering. For coagulation profile, it was essentially normal, except her INR and PT were slightly high, which indicated liver injury. On 18th April, they did bone chemistry on her, which was normal. On 20th April, they did KUB ultrasound, which showed features of bilateral parenchymal disease, bilateral kidney parenchymal disease. And management, she was given oxygen and breathamas, 15 liters per minute, started on cystazidine, 18 milligrams per kg, twice daily, continued on artesunate, omeprazole tablets were given, vitamin K was given because of the high INR, transfused 5 pints of blood throughout her admission. They did hemodialysis on her 3 times. There was a post-dialysis monitoring of blood gas analysis, UECs and FPCs. Fluid input and output was monitored, monitoring of RPS and blood pressure for hourly. ICU she was taken, there was ICU review due to worsening of her GCS. So progress, mother reported some improvement. Vomiting had resolved. However, she still had spiking fevers. Urine output improved. She had 3 wet diapers in 24 hours. Her jaundice was resolving. Her appetite was also improving. However, she was still in respiratory distress. Antibiotics changed on 14th April to meropenem, 20 milligram per kg per dose, 8 hourly, and augmentin 30 milligram per kg per dose due to lack of much improvement. On the same day, admitted to PICU and put on maintenance fluid and continued on artesunate, vitamin K, meropenem, and augmentin. Her fluid input on day 2 PICU was 700 ml and output was 200 ml. Her GCS returned to 15/15. Discharged from PICU on 16th April. UECs improved considerably by 25th April, urea levels coming down to 11 from 40, and creatinine levels dropping to 85 from 540. The leukocytes also dropped. She completed her course of antibiotics and antimalarial drugs by 26th April. Plan was to discharge her after monitoring her vitals. She was discharged on 29th April through the renal clinic. That's for the history.
Good. That was quite a very thorough presentation. So, Doc, at this point, maybe if you have any comments, I think you can come in.
Yes, thank you, Jamal. Thank you, Aisha, for that history. As you know, your diagnosis or management of the patients starts with a proper history and examination. That's a big part of getting the diagnosis and getting the right management plan for your patient. I think just as I've seen something about the progress. It's just a reminder, we use wet diapers a lot, yeah? But the right thing usually is to catheterize. So when you find a patient that has any form of renal impairment, or even neonates who have AKI, or any child with AKI, then the right thing to do is to catheterize. There is a formula that is not widely used, but in case you cannot catheterize for one reason or another, then for the weight diaper, you can calculate, you can estimate. You do the weight times 10 times the number of wet diapers per day to get the total urine output. And for stool, you do the same, but instead of 10, you do 5. So 5 times weight times weight times the number of diapers for stool. I think at this point, those were the only thing I could pick. At your level, I wouldn't go so much. I know you're mixed class students, so we'll see what comes up as we move along. Shukra.
So I proceed to the PowerPoint.
Yes, unless there's a question from the audience at this point, but I think we can take all the questions later, putting in mind that this was not your management of the patient. It's just a history that you picked. Let's proceed.
Sorry. Okay, so severe malaria. My outline was introduction, epidemiology, pathogenesis and life cycle, pathophysiology, clinical features, complications.
Aisha, just to, could you please put it on slideshow mode so that we can see it better, please?
Where is the slideshow?
Bottom left, bottom right, sorry. Bottom right.
Yeah.
At the bottom to the right.
Aisha, do you see where the 69% is?
Oh, right. Okay.
Right next to it.
This,
No, just come to the bottom here. You see where the 69%?
Yes.
Next to it, that one, yes. Next to it, yeah, that one.
Reading view.
Just no. Yes, good. Thank you. Continue.
So, introduction, epidemiology, pathogenesis and life cycle, pathophysiology, clinical features, complications, investigations and management. So, for my introduction, malaria is a potentially life-threatening parasitic disease caused by infection with Plasmodium protozoa transmitted by infected female Anopheles mosquito. There are 5 main species that cause malaria in humans. We have Plasmodium falciparum, Vivax, Ovale, Malariae, and Knowlesi. But in Kenya, it's the most frequent is Plasmodium falciparum. So in Kenya, there are estimated 3.5 million new clinical cases and 10,700 deaths each year. And those living in Western Kenya have an especially high risk of malaria. As it does in many countries around the world, CDC has worked closely with Kenya Ministry of Health to fight malaria. In 2020, there was estimated 241 million cases of malaria worldwide. The estimated number of malaria deaths stood at 627,000 in 2020. The World Health Organization African region carries a disproportionately high share of the global malaria burden. So in 2020, the region was home to 95% of malaria cases and 96% of malaria deaths. Children under 5 accounted for about 80% of malaria deaths in this region. So we have the life cycle of malaria Plasmodium. So in the human, as the mosquito bites, it introduces the sporozoites, and the sporozoites go to the liver. We have the exoerythrocytic cycle, which infects the liver cells. Schizons are formed, the schizons are ruptured, and they release the merozoites into the bloodstream. In the bloodstream, the merozoites enter the blood cells, the red blood cells, they mature to trophozoites. The trophozoites mature and they form schizons, and the cycle continues. Some of the merozoites become gametocytes, and the gametocytes go back to the mosquito as it bites the human. So we have the pathophysiology. Hemolysis of infected red blood cells and bone marrow suppression leads to anemia. A characteristic brown malaria pigment derived from the hemoglobin called heme is released from the ruptured red blood cells and produces discoloration of the liver, spleen, lymph nodes, and bone marrow. Severe parasitemia leads to excessive inflammatory reactions. Activation of the defense mechanisms in the host leads to marked hyperplasia of mononuclear phagocytes, producing massive splenomegaly and occasional hepatomegaly. Cytoadherence of infected red blood cells can result in obstruction of blood flow and capillary damage. Parasitic anaerobic metabolism can result in hypoglycemia and metabolic acidosis. So clinical features, we have general body malaise, headache, fever, cough and dyspnea, shaking, chills, arthralgia and myalgia, anorexia and lethargy, vomiting and diarrhea, and jaundice. Complications, you can have metabolic acidosis, severe anemia, pulmonary edema, altered consciousness, reduced glucose levels, hypoglycemia, acute renal failure, and infant death or miscarriage. Criteria for diagnosis of severe malaria. So for you to diagnose severe malaria, you have to have some of these symptoms. Detection of Plasmodium falciparum in the peripheral blood in the presence of any of the following features: more than 2 convulsions in 24 hours, impaired consciousness, Glasgow Coma Scale of less than 11 in adults, or Blantyre Coma Scale of less than 3 in children, inability to swallow. Prostration, generalized weakness, so that a person is unable to sit, stand, or walk without assistance. Hypoglycemia of less than 2.5 millimole per liter for children, and for children more than 5, or less than 3 millimole per liter for children less than 5. We have severe anemia of less than 5 grams per deciliter. Metabolic acidosis, bicarbonate levels of less than 15 millimoles per liter, a base deficit of more than 8 milliequivalent per liter, or venous plasma lactate of more than 5 millimoles per liter. Acute renal failure, plasma or serum creatinine of more than 265 micromole per liter, or blood urea of more than 20 millimole per liter. Respiratory distress, hepatic failure, jaundice, plasma serum bilirubin of more than 50 micromole per liter. Hyperpyrexia of more than 40 degrees, coagulopathy or DIC, hyperparasitemia of more than 2% per 1,000 per microliter, per 100,000 per microliter. So other investigations, we have complete blood count, reticulocyte count, urea and electrolytes, liver function tests, blood gas analysis, random blood sugars. Management, we have supportive treatment and definitive treatment. For supportive treatment, oxygen therapy is given, maintenance IV fluids, monitor and treat hypoglycemia, blood transfusion if in respiratory distress, and hemoglobin is less than 5 grams per deciliter. Dialysis in case of acute kidney failure. So for definitive treatment, we have severe malaria is treated with artesunate 3 milligram per kg for children less than 20 kgs and 2.5 milligram per kg for children more than 20 kgs. First day given at 0, 12, and 24 hours, then daily for a maximum of 7 days. These are my references. And
Thank you so much. Thank you so much, Aisha, for the amazing presentation. That was quite good. So I will invite Dr. Bajaber for more comments, and if you have anyone with any questions also in the audience, please you can put them down in the chats. Welcome, Doc.
Yes, so thank you very much, Aisha. That was very well done. You grasped the main aspects of severe malaria that we wanted to highlight. I'll make my comments, and then as people put in their questions in the chat box, and then we can cover the questions. So of essence, just trying to remember what Aisha presented is you have to know the different species of the parasites, where we find each of the species and what they cause, which conditions this species usually cause. The life cycle is very important. It goes without saying for most of you. These are things that are common in the exam, as well as the pathophysiology. Now, for the pathophysiology, when you're studying or when you're presenting, it's easiest to have a flowchart or a diagram of what, how this comes about, what are the main, pathophysiology or the virulence mechanisms, so on and so forth. You have to know how the sequestration comes about, the cytoadherence, and then in the pathogenesis as well, what causes the jaundice, what causes, the convulsions, and so on and so forth. The diagnostic criteria, I think, thank you for making the change last minute, Aisha. As she has put in the table, all those diagnostic criteria, symptoms. The complications, what are some of the complications? The renal complications. I think last week or just a while back, we had a grand round on AKI in severe malaria. And in as much as it's not very common, but you can get AKI, you can get nephrotic syndromes, among other complications. And then the treatment, So for treatment, you have to start your treatment as soon as possible. You diagnose urgently and you start your treatment urgently, because the death from malaria, severe malaria, within the first 24 hours is very high. And you initiate severe malaria, of course, goes without saying, you initiate IV treatment. And you also monitor the parasite density as you keep on treating the patients. So I think up to this point, we can take the questions and see what was not covered. I'll take it from there. Any questions?
I don't see any in the chat so far. Can put them down in the chat if you have any, or you can unmute and ask.
Yes, I have a question.
Mm-hmm.
Thank you, Aisha, for the wonderful presentation that you've given us. It's been really quite informative, and especially the history came out very well. Especially this someone who's coming from an malaria endemic area to having traveled to a malaria endemic area. I guess now the question would be, this is as far as I've gathered, as of the diagnostic criteria, especially with jaundice. My understanding is that it was initially jaundice was included as a sign of severe malaria, and then thereafter it was removed as to be a criteria. So I do not know why it was removed in the first place, but my understanding was that it was removed. I'm just wondering whether it's been returned, and if it is, how significant of a criterion is it? Thank you. jaundice alone, jaundice by itself, even in the presence of peripheral parasitemia. Thank you.
Thank you for the question. Aisha, okay.
I'm not sure about the answer. Please, Dr. Bajaber can help.
Okay. So yes, as you said, we have had several diagnostic criteria for severe malaria. I remember not just very long ago, we did not have jaundice as a diagnostic criteria, but the understanding of from the little reading that I've done on severe malaria and jaundice is that when you have severe malaria and you have an aspect of hemolysis, then you're, or rather, even if you've not diagnosed malaria at all, you have you're suspecting that the patient might be having malaria, and you have jaundice, then the jaundice pushes more towards the patient having malaria. And in this case, usually severe malaria, because by the time you get jaundice, then there's some hemolysis happening. And so remember, malaria, especially in our setup, due to the delays in diagnosing, especially with light microscopy, whereby we usually just use the RDTs or the rapid diagnostic tests, we have to treat the patients presumptively. And so for you to treat presumptively, you need to classify whether this patient is just the uncomplicated malaria or in the severe malaria. And so that was the explanation that with jaundice, you need to classify this patient as severe malaria. I hope that answers your question. I'll also share the up-to-date link on the same, the one I shared with Aisha for you guys to go through.
Thank you, Doc. Thank you.
Are you with us?
Thank you.
Anybody else?
Thank you.
That's good.
Doc, this I might just chip in, and also I have a question about pulmonary edema. Aisha, could you be knowing how that comes about? I'm not very sure.
Okay. Okay. So there is inflammatory cytokines that are circulating in the blood, and the fact that because of the increased hemolysis, we have sequestration of the red blood cells in the vessels. So we have vasoconstriction happening. At the same time, we have cytokines that are increasing in the blood. So because of that, the fluids will be extravasated into the pleural space, into the lungs. That I think that's why we have pulmonary edema.
Nice. Okay. Thank you. Any other person with the question, please? You can put it down in the chat if you have any, or you can unmute and ask. Or comments, anything you have not understood, you want to get a clarification on, you can put it down. Okay, so I think if then okay, let me see, someone is putting down something. Someone is asking, elaborate on the mechanism that leads to kidney injury. Aisha.
So because of the increased hemolysis, we have an increased parasitemia. We have the sequestration of the red blood cells also in the kidney tubules, which will occlude the vessels. It will prevent the urine from passing out. So I think that's why we have kidney failure. And also the increased acidosis. I hope I have answered the question.
Abdurrahman, I think that I hope that is clear. If not, you can again ask, no problem. Okay, another question. Why was a PPI in the management, omeprazole?
Because she was vomiting blood. She was having coffee ground vomit, which means the upper GI was damaged. The stomach was damaged because of increased total pressure from the hepatomegaly. So that caused the bloody vomiting, and also because of that, we needed to prevent ulceration of the stomach walls. That's why she was given PPI.
Thank you so much, Aisha. I hope that is clear. That was Isaac Abdi. Ayub is also asking, can you please repeat on pulmonary edema and respiratory distress in severe malaria?
Okay, for pulmonary edema, because of the sequestration of the RBCs in the vessels and the increased levels of cytokines in the blood that lead to vasoconstriction, and then because of the vasoconstriction, we have extravasation of fluids into the lung space that will lead to pulmonary edema. As for the respiratory distress, it's because of like they have severe anemia. So because of the severe anemia, there is not much hemoglobin circulating in the blood to take enough oxygen. So that's why they're having respiratory distress. And in our case, because she also had pneumonia, that's why she had her respiratory distress was high. I hope I answered the question.
I have a question.
Okay. Yes.
There's part of the history I think I didn't get well. Was a blood culture done on this child?
No, there was no blood culture done.
I think this is where Dr. we could use your knowledge or any other one who has information on this. My thinking is I'm of the opinion that perhaps a blood culture would have needed to have been done earlier in the management of this child, and of course do culture and sensitivity. Should we have suspected that whether it's should we suspect that the child also had a bacterial infection prior to the starting of the antibiotics? Of course, I understand that severe malaria is accompanied by bacterial infection, especially in children. But I think it would have been more fruitful or more utility. Should we have done a culture sensitivity that even for this bacteria that's already present, would have known what the sensitivity pattern is or susceptibility pattern is, that perhaps that would have shortened the duration of antibiotics or would have even informed us more on the choice of antibiotics. But I understand, of course, that broad spectrum and powerful antibiotics were given. That would be my contribution and my concern as well. Thank you.
Okay, I agree with you, but I think they didn't do the blood culture because already when she was coming from Mama Lucy, she was already on antibiotics. So even if they did blood culture, maybe it will have come negative. I think that's why they didn't do.
And they also didn't give us a report to show that it was done at Mama Lucy.
Yes.
Okay, thank you.
Just to chip in on that, thank you very much for that. Ideally, yes, blood culture should be done with any patient that presents, even with just a fever. Yeah, once you suspect any infection in a patient, then one of the first things to do is to do a blood culture. I think we've had mini rounds and grand rounds on sepsis for quite a while, and one of the things that is being insisted is do a blood culture. And this will help us in reducing antimicrobial resistance. Because most of the times you find out we are shooting here and there, a patient would have quite a number of antibiotics given from this to that. And so the right thing to do is, ideally, is you do a blood culture and you have a turnaround time the soonest you can, so that you narrow down to what they are sensitive to. But ideally, the right thing to do is you do a blood culture, and as you're waiting, you do broad spectrum, and then you narrow down. So remember, we are teaching you on how to become the best, or to do things the ideal way, and not what is being done in our setup due to one constraint or another. So yes, blood culture is very, very important. And I think they had, one of the differentials was septicemia, which ideally a blood culture should have been in the plan. That could be an oversight. But please, yes, always remember to do blood cultures for your patient.
Thank you very much, Doc. I'm not seeing any more questions in the chat. Oh, so I suppose we've reached the tail end of today's discussion. I want to again thank our presenter today, Aisha, for the good work you've done. Compiling and clerking and presenting is not an easy one. So thank you so much for giving us such a wonderful presentation, and also to Dr. Bajaber for having accepting to join us, first of all, in a short notice, and also giving us sharing the much knowledge you have about severe malaria. And also thank you to all our participants. Inshallah, we'll continue the series every other Monday with the different cases as usual, inshallah. So at this point, if we don't have any more questions, I think we can call it a session. Yeah.
Thank you.
Shukran.
Shukran, good work, sound team. Aisha, keep this going, inshallah. Jazakumullah khair.
Thank you for the presentation.